everyone. Here's Regina Bokenkamp, chairperson of the working group Interventional Cardiology from the AEPC. Today, I proudly present you our new YouTube channel. The AEPC YouTube channel is a project driven by the COVID-19 pandemic. As a working group, we wanted to give our juniors the chance to learn from the seniors while teaching courses had to be cancelled or postponed. Now we intend to upload educational videos on a regular basis to this channel. Many thanks to all seniors who already offered to share their content. Suggestions of topics are still welcome. Before we start, a few remarks on the format. You will all agree that interventionalists are a kind of craftsmen or craftwomen. So we wanted to use a master and apprentice concept for the transmission of knowledge. Today, our master is Daniel de Wolf from Brussels University, and our apprentice is Maria Álvarez Fuente from the University of Madrid. First, we will have the lecture of Daniel de Wolf on interventional treatment of the coarctation, and subsequently Maria will ask Daniel the question. Daniel.
Good morning, good afternoon, good evening, good night, or whenever you like to watch this presentation about interventional therapy for coarctation. Here you see an overview from the things I want to share with you. I guess that some of you still think that coarctation is a common and simple disease. Well, unfortunately, it's not. It remains a rare disease, although well known to congenital cardiologists. The presentation can be different for individual patients. Diagnosis is not always straightforward. Coarctation can be complex and associated with other types of congenital heart disease. Treatment seems simple, but outcomes are far from perfect, and long-term complications are not uncommon. The pathogenesis is not entirely clear, but changes in the aortic wall are the rule. There are two hypotheses. One, a reduced antegrade intrauterine blood flow causing the development of the fetal aortic arch. And the second one, migration or extension of ductal tissue into the aortic wall. You have vascular changes at the isthmus forming a posterolateral ridge. There are aortic wall abnormalities in the pre-stenotic aorta that are already there in newborns, increased stiffness and decreased distensibility, increased collagen and cystic medial necrosis. There can be a genetic predisposition in family members, other LVOT obstructions too. 5 to 15% of the girls with the coarctation have Turner syndrome, and there can be acquired coarctation in inflammatory diseases of the aorta, such as Takayasu arteritis. Here on this slide, you see some anatomical samples. On the left side, you see the posterior indentation in the aortic wall, just below the left subclavian artery. Here you see a very tight stenosis seen from below, and on the right side, you see an aortic hypoplastic aortic arch. Pathophysiology seems quite simple and is indeed. The vascular obstruction leads to increased afterload and hypertension. Then a collateral circulation develops and severe left ventricular hypertrophy can cause heart failure. You see the different pressure curves above and below a coarctation with the pressure gradient and flattening of the downstream pressure curve and equalization of the pressures after dilatation. Newborns often show a more critical stenosis, and afterload increases too fast after ductal closure. This results in severe heart failure and shock. So as I mentioned previously, the presentation can be different in newborns and infants compared to older children and adults. The critical coarctation in newborns and very young infants is duct dependent and presents as heart failure and shock, as I said. Right ventricular dilatation and pulmonary hypertension are the rule, and hypoplasia of the arch is common, and associated congenital heart disease is not uncommon. Coarctation is often an accidental finding in older children with hypertension or severe headaches. In adults, coarctation can sometimes be the reason of heart failure. The natural history of unoperated coarctation, as you see on the right upper side, is marked by early atherosclerotic changes, cerebrovascular bleeding in cerebral aneurysms, and early mortality. More than half of the patients with unoperated coarctation die before the age of 40. The most important imaging technique to assess coarctation in children is echocardiography. But echo is unfortunately operator dependent and depends on the quality of the echo windows, especially suprasternal view. With echo, you can look for associated lesions for left ventricular hypertrophy and function, and for dilation of the ascending aorta. You should inspect the arch and look for eventual hypoplasia of the transverse arch, to look for the location of the discrete stenosis, evaluate eventual tortuosity and distance between stenosis and the left subclavia. Look at the pulsatility in the abdominal aorta, and Doppler provides additional information about pressure gradients, although the morphology of the Doppler signal, the Doppler velocity in the abdominal aorta, and any diastolic runoff. In older children and adults, an experienced echocardiographists can get decent images too, as you see here. What I find helpful is Doppler interrogation of the abdominal aorta, which is helpful for establishing the diagnosis if the suprasternal view is poor. Here you see another example of a coarctation in an adult with a typical sawtooth waveform and a flattened abdominal signal. In older children and adults, and in cases of recoarctation, certainly CT and CMR provide images of superior quality. They provide additional information that can be useful for the choice of the best treatment and the choice of the material in case of an interventional treatment. Here you see an example of a CMR. You see the collateral circulation covering the coarctation, and here you see the coarctation after filtering that collateral circulation. The advantage of CMR is that it doesn't give any irradiation, but unfortunately waiting lists for CMR are long in most centers, and for small children you need sedation. Here you see an example of CT, a very tortuous long coarctation segment, and you see the superior resolution of CT and 3D CT. CT gives irradiation, but not a very important degree. So you have to be careful about irradiation, especially in smaller children, but it doesn't really add too much to the total degree of irradiation in most children, and it's readily available, and in most children you don't need any anesthesia. Once a diagnosis is made, of course, treatment is the next step, and the goals of coarctation treatment are on the short term, of course, relief of symptoms, good immediate results, and a minimal complication rate, including vascular damage to the aorta or the femoral artery. On the long term, treatment should improve prognosis and ideally lead to event-free survival. However, residual coarctation, hypertension, aortic aneurysms, and the fate of stents in growing children remain real concerns during follow-up. What are the indications for treatment, and what are the different techniques available? Well, for newborns and infants, heart failure is the most important indication. For older children and adults, the indication are the resting gradient. Here, correct measurement is important because, in my opinion, and not only in my opinion, Doppler gradients are not reliable. Normally, you should measure pressure differences invasively without anesthesia, but you can also use cuff blood pressure gradients between arms and legs. Beware of any possible femoral artery stenosis if the patient already got an intervention. Hypertension, significant collateral circulation in cases of low gradients, and narrowing of the aorta are other possible indications. If you look on the next slide to the algorithm of the ESC guidelines, the interventions of recoarctation are put in a table. When there is arterial hypertension and you have a peak-to-peak gradient of more than 20 millimeters of mercury, you have an indication for an intervention. When the peak gradient is below 20 millimeters of mercury and you have a more than 50% narrowing of the aorta, there is an indication for intervention. If there is no arterial hypertension, but a clear peak gradient of more than 20 millimeters of mercury, there is, in my opinion, an indication for intervention. If the peak gradient is lower than 20 millimeters of mercury and the aorta is narrow to more than 50% of the aorta at the level of the diaphragm, there might be an indication. If not, there is no need for any intervention according to these guidelines. The technique of choice for the treatment of coarctation depends on the age of the patient and on the anatomy. Below the age of 4 months, most centers choose surgical correction, and during the operation, the surgeon can take care of any associated arch hypoplasia, as you see here, using an extended end-to-end anastomosis. Results of surgery are good and mortality is low, and hypoplastic transverse arch and more complex congenital heart disease can be treated in one operation, as we said before. However, residual coarctation is not rare, ranging between 5 and 20%, depending on the center, depending on the surgeon. The alternative could be balloon dilatation, of course, and this is certainly the therapy for any residual coarctation. But for native coarctation, the results are disappointing, as you see here, with recoarctation rates above 50%. In infants older than 4 to 6 months and young children, the choice for surgery or balloon dilatation is made on an individual basis. Most centers choose for surgery if there is a hypoplastic transverse arch for obvious reasons, as you take a look at the disappointing results of balloon dilatation if there is a hypoplastic arch here. But many centers still prefer surgery as their first choice therapy here for any native coarctation in this age group, anyhow, regardless of hypoplasia or not. Nevertheless, new data become available that support the choice of balloon dilatation in this age group too. In this article by Sandoval, you see that results of balloon dilatation in infants between 3 to 12 months are not disappointing, with a recurrence rate of 20%, and that the rate of aortic wall injury is reasonably low. In this age group, the rate of significant aortic aneurysms after balloon dilatation is around 1 to 2% compared to the overall literature data for aneurysms after balloon angioplasty in all ages of 5 to 7%. Stenting is not yet endorsed by many in this age group, but at this moment, smaller stents become available that are dilatable up to adult sizes, and maybe resorbable stents could be interesting too in the future. In older children and adults, stenting has become the treatment of choice nowadays. In the next few slides, I gathered some data from the CCISC consortium and the COAST project. They show superior results of stenting and surgery and the higher incidence of aortic wall complications with balloon dilatation. Pressure gradients for sure are lower after surgery, but the rate of complications is also higher after surgery. And of course, hypertension is an important endpoint predicting long-term outcome in coarctation patients. And CCISC and COAST data confirm the benefits of stenting for hypertension control. But note that still many patients, up to 25%, remains hypertensive though, or on antihypertensive drugs despite successful stenting. As I mentioned before, smaller profile pre-mounted stents become available for use in children with still important growth potential. Their low profile decreases the risk of femoral artery injury. They have a profile of 5 to 7 French. And even more importantly, thanks to their hybrid cell design, they can be dilated up to adult sizes later on in life, with only limited foreshortening and preservation of their radial strength. And especially the Valeo and Formula stents have already been studied for the purpose, as you can see in the next 2 slides, and they keep their configuration and radial strength when updilating them to adult sizes, and foreshortening is limited. Here you see an example of a Valeo stent in a small child. Maybe the stent is a little bit too long. The choice is perhaps not the best one we could have made, but on the other end, it won't be an issue when the patient becomes an adult. The technique of vascular access is important too. The aims are pretty simple. Get there, protect your entry vessel, and reduce post-interventional bleeding. For what protection is concerned, we prefer to use the glide sheet. It's a coated sheet that is thin-walled, resulting in a lower outer diameter. It has some inconveniences though. Beware of accidental retrieval from the vessel during manipulation, so secure it when you use it. And sometimes balloon removal can be tricky, damaging the thin-walled stents. Here you see what we use. We use echo-guided vessel puncture. It, in my eyes, avoids vessel damage from several punctures in the groin. You can aim for the larger common femoral artery, and it helps you in achieving a single wall puncture, which can be important to control bleeding afterwards. Practice is very important. There is a learning curve, so if you use it all the time. Here you see we add some gel on a vascular probe, a hockey stick for very small children. We cover the entire probe in a sterile sleeve, add some sterile gel. These are the images of the groin. We keep the probe ourselves in our hands while sticking the needle and then advancing the sheet after a successful puncture. Here you see the images we get. What you want to see is the 2 vessel image with the artery here and the femoral vein here. That means that you're aiming at a common femoral artery. You don't want to see that 3 vessel image, because then you're aiming too low and you risk hitting the superficial femoral artery or the deep femoral artery, which will be a problem for post-interventional bleeding control. Of course, you can compress the artery after the intervention. And if you want to compress a groin for half an hour, that's okay to me, but maybe it's less okay for your staff or for your busy program. So you can use some techniques for post-interventional vascular closures. We use two techniques. First, as you can see here, the ProStar technique. It's a little bit more demanding on your surgical suture skills, but you need only one device. We prefer the ProGlide devices, are two devices needed when you use a sheet larger than 8 French. And you need to insert them at the start of the procedure. Also a suture mechanism, but less surgical skills are needed. As you see here, this little device tightens the sutures at the end, and look at the nice dry field immediately after the intervention is finished. When the femoral artery approach is impossible, sometimes femoral arteries are occluded, you can use the antegrade approach in young infants through the femoral vein. It's more cumbersome, and certainly you won't achieve a very stable position of your balloon. It's more cumbersome. I don't like it. In very low birth weight premature infants, when you do a bailout procedure, you can use a cut down of the carotid artery by the surgeons. This is an example of a premature infant with a bailout procedure in Leiden. When I was there, participated in this one with Regina. You see the angio, the ductus is still open, insertion of the stent through that sheet. You don't have a lot of room for the sheet in the artery, so beware of retrieval, accidental retrieval of the sheet, but at the end, the result looks nice. Sometimes you can't cross a very tight stenosis from below. As you see in this example, unfortunately, the image is not working, but in those circumstances, you can stick a sheet in the femoral artery, in the radial artery, and approach the coarctation from above. You see the very tight stenosis here. You can introduce what we do, a right coronary, a Judkins catheter, push a coronary wire and snare it from below, and then advance over that arm to leg arterial loop, a balloon, and pre-dilate the very tight stenosis, and continue to do your procedure from below. Imaging during the procedure is of course quite important, but in my eyes, imaging before and after the procedure can be of crucial importance too. You want to see the anatomy. You want to be able to choose and size your material, and you can choose. You can use your 3D imaging acquired before the procedure as overlay during the procedure. Imaging during the procedure is important for choosing your landmarks, for sizing, and for assessing your results. Imaging post the procedure is important to assess your results, and certainly as follow-up for any complications. During the procedure, you can consider 3D angio for guidance. If there is no pre-procedural imaging available, always use biplane imaging and use several projection angles. And important, never lose any wire position once you start your intervention. Here you see some standard views. I use them all. I'm looking at the views. When I want the best views for measuring, I look at the elongation of my catheter. You can use 3D rotational angio. There are some caveats. You need to use diluted contrast because the rotation takes a few seconds and you need an injection during the complete rotation. And you can use pacing for better contrast quality if your first injection is not working. We prefer to use our 3D CMR or CT images as an overlay during the procedure. It needs segmentation and synchronization and takes a certain learning curve. But the advantage is that those images, this overlay, rotates together with your tube. And looking at the overlay, you can use the best angulations for your biplane imaging during the procedure. Here you see an example of rotation of the overlay. It's not really synchronized in this image during the procedure. And you see that indeed, while your tube is rotating, your overlay is rotating. What about the choice of the material? Well, for the balloons, profile and compliance are important. I prefer a vascular balloon that's less compliant and tolerates a higher pressure than a valvular balloon. Size is chosen according to the size of the transverse aortic arch or the descending aorta at the level of the diaphragm. For stents, size, cover, profile, length, strength, flexibility, and dilatability are important. For instance, radial strength depends on the materials used, on the numbers of cells in a cross-section, on the designs of the stents. There are some data available. Bjorn Coles wrote a nice recent article about it. In summary, closed cell stents have more radial strength than hybrid stents. Multiple stents have more radial force than single stents, and hybrid stents are a little bit more flexible. Another advantage of hybrid stents is that dilatation of side struts is easier through open or hybrid cells. The balloons you can use for delivery and dilatation of the stents are essentially single or balloon-in-balloon types or bib balloons. A bib balloon allows an initial inflation of a smaller internal balloon and in a second time inflation up to the desired diameter with the larger outer balloon. And as long as you only inflated your inner balloon, you can adjust the position of the stent a little bit, and inflating of the inner balloon prevents diabolar deformation and foreshortening when you inflate your outer balloon. If we choose a single balloon, we prefer the shortest possible for the chosen stent. This also decreases diabolar deformation and shortening. The different types of stents are essentially bare or covered with closed or hybrid cell design, with a small, large, or extra large profile depending on the maximal expansion diameter. And at last, you can have pre-mounted or unmounted types of stents. Cover is essentially PTFE, and look whether the ends of your stent are free or covered. That can be important for positioning a stent in the neighborhood of a side vessel. If unmounted, you need to crimp the stent on the balloon. A pre-mounted stent has a lower profile, but the disadvantage is that you need more material on the shelf. What is important if you crimp an unmounted balloon is that you leave your guide wire in the catheter shaft. I coat the balloon with a little bit of contrast to prevent it from moving, from the stent from moving over the balloon, and I use an umbilical tape looped around the stent for tight crimping. And I always load the balloon stent ensemble in a short sheet of the desired French size before pushing it through the valve of the long sheet. As you see here, the stylet of guide wire remains in the shaft during crimping, and here you can use an umbilical tape for additional tightening. Sheet size differs for bared or covered stents and for pre-mounted and unmounted stents. What about the use of bare or covered stent? The jury is still out, and you will see that there are different attitudes in Europe compared to the States. What my personal opinion is, I use a covered stent if there is a very severe coarctation, if there is a coarctation with a patent ductus, if there is a coarctation with an aneurysm, or in case of arterial tortuosity, a coarctation in older patients. I'm not sure about the real cutoff age. Certainly in Turner syndrome patients, after balloon dilatation with the wall injury, you use the covered balloon as bailout. If there is a fractured stent with struts protruding in the wall, and in case of aortic inflammatory disease. I avoid the use of a covered stent when crossing neck vessels and when deploying a stent in the lower thoracic aorta to avoid occlusion of the artery of Adamkiewicz and avoid spinal cord injury. What about device positioning? There are some do's and don'ts. Start the intervention with an extra stiff exchange guide wire in position and never lose that wire position. Don't move or remove the balloon or stent without the guide wire in position. Check your position before inflation. When dilating a balloon, if the waste doesn't disappear by manual inflation, switch to controlled inflation with an indeflator with a manometer. Always deliver a stent through a long sheet. The sheet size for most stents is, for a bare stent, it's the balloon profile and 2 French edit. For a covered stent, it's the balloon profile and 3 French edit. Always test it in a short sheet before introducing it in your long sheet. Don't load it unprotected through the sheet valve and confirm correct stent position on the balloon before deploying. Don't push the stent out of the sheet to uncover, but peel the sheet off. Confirm stent positioning in the aorta before deploying. And if you don't use a bib balloon and the coarctation is not too tight, always use rapid pacing for stability. Don't remove the balloon unprotected through the stent, but try to advance the sheet over the balloon while deflating it. And take care not to dislodge the stent. Here you see a simple balloon dilatation, recoarctation, tight balloon dilatation, and afterwards a nice result. So it can be simple. Also in a native coarctation, here you see a native coarctation in a younger child. We ballooned it and we had a nice result afterwards. So things can be simple. If you want to deploy a stent in a coarctation that's not too tight, we always do it under rapid pacing. You can pace the right ventricle, but you can also pace the left ventricle by using a safari wire. That's a wire the TAVR people use, forms a loop in the left ventricle, touches the left ventricle and allows you to pace your patient from the left ventricle, preventing you from having to stick the femoral vein. What I like during my pacing is decreasing the systolic pressure by half and reducing the pulse pressure. Use pacing rates of 180, 190, 200, test it before you deploy your stent, This is pacing at, I guess, 200, and this can be a little bit too rapid. You see the very irregular pressure curve, and this is, in my opinion, dangerous and could lead to ventricular fibrillation. So test at a lower rate and get up until the rate you desire and you feel safe. This is a moderate coarctation, positioning of the stent here, and then you see what's happening, deploying the stent under rapid pacing with a nice and stable position. This is another example where you want to confirm your position. The coarctation is not too tight. You position your stent, and through the sheet inject some contrast and confirm a correct position. As I said, you don't want to push your stent out of the sheet and risking to dislodge it. But on the other hand, what you want to do is peel off the sheet, as you see here, and keep your stent position stable. When you inflate your inner balloon when you're using a bib balloon, you're still able to reposition your stent a little bit and confirm your position afterwards. And afterwards, you deploy your stent by inflating your outer balloon, and you see that indeed diabolum deformation is limited, and certainly stent foreshortening is limited. Here you see another example where we position the stent in a rather asymmetric large aorta. And what you can do is when you want to refine stent delivery, here you see the stent delivered. It's a tube, but still not nicely positioned against the wall. You can flare the ends of the stent proximally and distally, and afterwards you get a pretty decent result, and sometimes a result that looks even perfect. If your stent reaches the aortic wall and it's not completely perfect, in my opinion, you shouldn't waste time in flaring that further on. Some tricks and pitfalls. Sometimes things are not that easy, and creativity and tenacity become important. So when the going gets tough, the tough get going. Here you see an example that I already showed you before. And unfortunately, again, the angio is not working here, but here you see the image. We chose to approach it from the radial artery. You see a very tight stenosis, introduce a coronary wire through a right Judkins catheter, snare it from below, dilate the very tight stenosis with a small balloon coming from below. Here you see the result, and then advancing our stent again, coming from below, adjusting the position and inflating it. Here we chose a covered stent, and you see the result afterwards is quite nice. Another example where we approached the coarctation from above is a coarctation, very tortuous, very narrow coarctation, tortuous aorta. We snared a wire introduced through the coarctation from above, snared it from below, inserted a very an extra stiff wire, mounted a balloon, pre-dilated the tight coarctation, then advanced our extra stiff wire into the ascending aorta, straightened the course of the coarctation, and then we could advance from below our sheet. And in this patient, we chose to deliver a bare stent, not a covered stent, inflated cautiously, the covered stent on the shelf for if things got worse. That was our result at the end. Our radiologist checking it afterwards went berserk, but in fact, the patient is doing fine. This is another example of a long segment coarctation. We know that in a lot of patients with those long segment coarctation, the aortic wall is very thin, so we prefer to use covered stents here. We mounted a very long covered stent. At the time we did this, we ordered a custom-made long CP covered stent, but now there are some Optimus and B Graft stents available of around 6 centimeters of length. This is inflation with the bib balloon. Here the outer balloon is inflated, and here we flared a little bit, and you see afterwards a very nice result with the complete tortuous long segment covered by the stent. Sometimes the location is unusual and severity of clinical findings doesn't fit the image, and the pressures in the arch look somewhere else. Then here we had a patient in which we thought the patient had a recoarctation, but when we looked at the images, measured the pressures in the possible recoarctation zone, we didn't find any gradient, and it didn't look like a recoarctation. And when we looked a little bit further below, we saw a coarctation in the descending thoracic aorta, almost at the level of the diaphragm. And that's what we confirmed here. And we chose to insert, of course, a stent, a bare stent here, because we were so low that we were afraid of occluding the spinal cord artery here, a Dankiewicz artery, but you see the nice result afterwards. Here you see a coarctation that is even lower, so be careful when you don't find your coarctation and you're sure there is one, look over the complete aortic arch and aorta. What about the hypoplastic arch? Is it best not to touch it? Will it grow after coarctation repair or balloon dilatation? And then the question, is a large stent worse than a more compliant native long narrow segment? We did some animal experience in our own center, and we learned that even a low gradient stenosis induces more ventricular arterial impairment than a long, stiff, large stented segment without stenosis. So we would advocate dilating or stenting any hypoplastic segment if necessary. Let's have a look at the definition of hypoplasia. It means that the transverse aorta or any part of the arch located upstream from the coarctation measures less than 50 to 60% of the normal diameter. The aorta at the level of the diaphragm is usually considered as the normal diameter. Here you see some examples. This is a residual coarctation with a severely hypoplastic, a distal hypoplastic arch. On the angio images, you have the impression that there are some discrete stenosis here. We checked this with a low pressure balloon and we saw some indentations, so we decided to dilate this hypoplastic segment with a higher pressure balloon, and doesn't look that bad. It's still hypoplastic, but you have the impression that this discrete stenosis disappeared. And to our surprise, I have to confess, the echo afterwards was much improved and the Doppler gradients reduced. Same with the non-invasive gradients. Here we have another example of a tortuous hypoplastic segment, and it was very difficult to see where the gradient was, so we decided to cross the complete area with a bare stent, and the result was not that bad. Maybe the stent was a little bit too long, but we chose to have a longer stent that followed the curvature in order to try to avoid protrusion of the struts in the wall here. Here you see what happens when you jail the left subclavian while covering an hypoplastic arch. At that moment, what we choose is to open the struts and reopen the ostium of the left subclavian. Even if this is not a covered stent, we introduce a catheter. And well, I like to introduce a coronary wire and dilate the struts with the high pressure balloon with a nice result afterwards. And here you see how it looks on a CT after the procedure. Here another example of a tortuous hypoplastic arch. Again, we stented it, and again, after flaring the distal and the proximal parts, we dilated the struts and opened the left subclavian. Sometimes you have a very tight stenosis, resistant to dilatation or with important recoil. And then you have to remember that 2 stents are stiffer than 1, have more radial strength and more resistance to any recoil. This was a patient with a hypoplastic distal aorta. After inserting our first stents, we saw some recoil, and indeed the result wasn't perfect. We decided to insert a second stent to increase the strength and cover that proximal hypoplastic part too. But after positioning the second stent, we still thought that the result was not perfect. We still had a pressure gradient, and we decided to put a high pressure balloon in the unit. And you see that after inflation of the high pressure balloon, the stent unit looked a lot better than before the configuration, and our gradient disappeared. Sometimes it's a little bit more tricky to deliver a stent and preserving the flow to arm or neck vessels, certainly if it's a covered stent. I avoid covering the origin of the carotid arteries, but sometimes the origin of the left subclavian is more or less part of the stenosis, and I prefer to keep it open, as you saw before. In cases where I have to deliver a covered stents, I rely sometimes on a double balloon and double wire technique. What I do is place a wire in the aorta, one in the left subclavian, and mount 2 balloons or a balloon and a catheter on the 2 wires and crimp a stent on this unit, as you see on the images. Due to the oval configuration of the unit, the sheet you need is a little bit smaller than expected if you would use a single balloon and stents. Here you see indeed a coarctation that is very near to the left subclavian origin. Here we used the bare stent, so what we did here, it was not really necessary to use our double balloon or double wire technique, but I didn't want to insert my stent in the arch here. So what we did is we had our 2 guide wires, we mount our sheet, we position our stent and peel off the sheet, and then we inflate our 2 balloons together, opening the stent nicely in this, well, quite resistant segment. Here you see the situation before stenting, and here you see the situation after stenting with a nicely open left subclavian, a nicely configuration of the arch and disappearance of the gradient. Sometimes you can, here you see another example where we chose, because it was a tight stenosis, to deliver a covered stent. Here you see the stent, the sheet is already gone. The 2 balloons nicely opened it tulip-wise into the coarctation area, and you see the result after fully dilatation of the distal part of the stent 2 with a nicely open left subclavian artery. This is an example where you deliver your stent on one balloon because it was a rather straight course, and you position your second wire and balloon afterwards, and you get exactly the same images as in the previous examples where we used the two-wire, two-balloon technique. It's a little bit different, depends on the anatomy. What to do when there is an aneurysm and what to do in a Turner patient? Well, if there is an aneurysm, we use a covered stent. These are examples not from my lab, but from an article from Gianfranco Butera with nice images. Here, an aneurysm after coarctation repair. You put in a covered stent and cover the aneurysm. Here is aneurysms in a native coarctation, and again, this complete segment is covered with a covered stent, excluding the aneurysms and preventing severe aortic wall injury. Can be a little bit tricky if your aneurysm is in the transverse arch and you need a stent there covering the left subclavian artery. Well, first insert a sheet in your radial artery. Then after positioning of the stent and deploying the stent, a covered stent, you can perforate the roof of the stent from the radial artery with a coronary wire, insert a coronary balloon, inflate it, and then you have reopened your jailed or occluded left subclavian artery here. If you do a Turner patient, you can just position your stent as usual, but we always use a covered stent in Turner patients because we know from other articles, and here is one study in which our group participated too, that the risk of vascular injury, severe vascular injury, here you see images of an aortic rupture covered after stenting, that the risk of aortic wall injury in Turner patients is high. Here is another example. With a bare stent, you have an aneurysm through the stent, and even if you use a covered stent, you can get aneurysms at the proximal of distal ends. So be prepared for disasters if you do Turner patients. Sometimes results are disappointing, or we think they are disappointing. What can you do? Here you see a tortuous aorta, coarctation. We inserted a stent and we're not very happy with the result because we thought that the struts were protruding, maybe not into the aortic wall, but towards the aortic wall. We are not happy with the results and decided to put in another stent. That is what you do when you put a stent in a stent. First, you advance your sheet. You advance your sheet to the end of the stent. Then you advance your stent, your second stent, into the first stent, still into the sheet, and then you peel off your sheet after you got correct stent positioning. That's what we did. We inserted the second stent, we straightened the stent course in the aorta, and we had a very nice result afterwards. Sometimes it's really disappointing. This was a moderate stenosis in a younger child. We dilated it, no result at all. And the patient parents and the treating physician refused to have a stent inserted in this young patient, and we had to send the patient to the surgeon afterwards. Here is a patient with a residual coarctation. a very short arch. We inserted the stent and we wanted it to end halfway the left subclavian, but unfortunately when inflating the stent, it ended too proximal. We tried to dilate the proximal part of the stent and have a better configuration. We opened the jailed left subclavian, but at the end, when you look at the angios, the stent is still protruding in the ascending aorta. We weren't too happy about it, but decided to do nothing, and the patient is still doing well. Here is another patient with a hypoplastic transverse aorta. You see the hypoplastic part here. You see the stent here. Here is the left subclavian. Position of the stent looks nice. We checked our stent position. On the frontal image, it was okay, but on the distal image, and you don't see it anymore, but on the distal image, here is the hypoplastic segment, and the stent moved more proximal. What we did at that moment is secured the position of the stent. Here you see still the hypoplastic part. You see the position of the stent. We inflated it further on to secure the stent and flared it a little bit more proximal, and then positioned a second stent more distally into the first stent. And you see at the end a very decent result. Here, what you can do when you have some recoil or intima proliferation. This was a patient in which we dilated the coarctation. Was not perfect afterwards. There was some intima proliferation, as you saw here. We thought that maybe we should align the stent a little bit more with the proximal aorta, try to get a little bit straighter course and incorporate that proximal aorta in our stent. Inserted the second stent at a little bit longer stented area, and afterwards our result was fine. There was no intima proliferation anymore and no gradient anymore. Should we try it all? What about the problem of the carotid arteries? Do we have all the answers? Can we tackle any situation in children and adults with interventional techniques? For example, what about this one? A male of 16-year-olds, 1.75 meters, at a neonatal coarctation, end-to-end anastomosis, hypoplastic transverse arch. Initially, there was no problem, not an important gradient, no hypertension. Gradually, the gradient between arm and leg increased up to 30 millimeters of mercury, and at the last visit, he had clear hypertension, confirmed by what we always do, ambulatory blood pressure evaluation. On CT, you see that there was a severely hypoplastic arch of 8 millimeters, and descending aorta at the level of the diaphragm measured 16 millimeters. Unfortunately, the origin of the left carotid is in the middle of that transverse aortic arch. What should we do? What can we do? In my opinion, there are two options. First, complete surgical reconstruction of this aortic arch. And the second one is insert a bare hybrid stent here under rapid pacing, a diameter of trying to achieve the 14-16 millimeters of the descending aorta here in order to try and avoid redilatations, open the origin of the left subclavian of the left carotid completely by ballooning it through the side struts. My questions here are: what if there is an intervention, a re-intervention needed? What are the risks of debris embolization through that left carotid? What are the risks of dissection of the left carotid? I discussed this with our surgeons. I discussed this with Professor Qureshi also. And for this patient, we decided not to stent it, but to send him to the surgeons. Is this the right attitude? I don't know, but I'm very carefully about crossing carotid arteries. In conclusion, after this long presentation, interventional treatment is a very reasonable option for the treatment of coarctation beyond infancy. Balloon dilatation is a treatment of choice for younger children with recoarctation and a safe alternative for surgery for native coarctation in the young child too, according to the latest studies. Stenting is a treatment of choice for the older child and the adult with recoarctation and coarctation. An intervention in a patient with coarctation can be simple, but can be a demanding procedure. Choose the safest and surest access and avoid post-procedural bleeding. An intervention for a coarctation is rarely an emergency, so use and integrate pre-procedural imaging. Choose the type and size of your material in accordance to the anatomical findings. Avoid complications if possible, of course, and be aware on how to avoid them. Deploy your balloons and stents in a stable position or enable stability by using a long sheet, a stiff guide wire, rapid pacing, and the correct or best approach. Respect the carotid arteries and look actively for possible complications and treat them. Very important, ensure lifelong follow-up for your patients, including ambulatory blood pressure measurements, exercise testing, imaging of the aortic arch and the descending aorta, especially in case of associated bicuspid aortic valve or Turner syndrome patients. Thank you very much.
Thank you, Daniel, for your amazing talk. It was very interesting and thoughtful for me, I think for every junior and for everyone who is interested in interventional cardiology in the pediatric and congenital world. I thank also Regina for presenting this amazing and very exciting new project endorsed by the Interventional Working Group of the AEPC. As the junior counselor of this group, I'm happy that junior members are really involved in this project, and I'm sure young interventionalists will appreciate this webinar series on YouTube channel. Speaking on which, I invite everyone who is interested in joining the junior members group to contact me. You will find the contact details below in the description of the video. And let's not waste any more time. I will give the word to Maria from Madrid. She's a member of the juniors of the Interventional Working Group, and she will be here to spice up the discussion regarding the coarctation, interventional treatment of coarctation. Thank you, Maria.
Thank you very much, Domenico, for the introduction. And thank you very much for Dr. De Wolf for the wonderful and educational presentation. I have some questions on three aspects. One is the before the procedure, what we do, some questions on the procedure, and some questions on the follow-up. So maybe we can start with the preparation of the patients. And you talked about CT scan prior to catheterization. So I would want to ask, in which patients, supposedly complex patients, do you perform these CT scans? And do you recommend it in only these kinds of patients or in all patients?
Okay, Maria, thank you for the questions and thank you for your interest. If you allow me, I would like to share my screen and have a few slides that can illustrate my points. In my opinion, echocardiography offers enough information about the anatomy the size of the coarctation and the transverse arch in the young children, especially if you just want to do a balloon dilatation. And I'm really not convinced that the CT before the procedure offers many advantages there, because most balloons should be available on the shelf, and the choice of the most suitable balloon for a dilatation can be made with the images of the conventional angiography during the procedure itself. In the young children, CT overlay is not really necessary in case of that balloon dilatation, because I don't think that meticulous positioning is an important issue then. And so in my opinion, the benefits of CT do not really justify the additional irradiation exposure. On the other hand, for older children and adults, echocardiography is not accurate enough to procure all the anatomical details that are necessary for the choice of the materials and for the treatment strategy, I think. There, a CT or an MRI offers nice 3D anatomical details with nice high resolution, and that will allow you to plan the intervention and choose or even order the necessary materials, as not every center, certainly not ours, has all types of stents or all stent lengths and diameters available on the shelf. Let's have a look if it works at the second slide. Yeah, here you see that a CT or an MRI that has been acquired before the procedure can nicely be synchronized with a cath lab fluoroscopy. It can be used as an overlay that rotates together, as you see there, with the imaging plane that will allow you to choose the best imaging plane from the start, and allows you to position your stents very accurately also. Of course, to be honest, we still use small contrast injections through the long sheet to confirm the precise real-time position of the stent before deploying it. As you can imagine, that a stiff guide wire and a long sheet tend to distort the anatomy a little bit. You're satisfied that answer?
Well, it's a beautiful overlay with the CT scan, and sometimes we have some troubles overlaying our images. So with which structures do you do this matching? So
we have a Philips machine, and we can use whatever CT or MRI on whatever machine acquired. So we don't need a Philips CT or MRI anymore. In the beginning, that was the case. And then it takes some experience. You have to do the segmentation, choose the images, and then what you need is really a reference on the, before we used the rotational plane of RAO and LAO, but now it's just a frontal fluoro film and a lateral film. And then you just synchronize your 3D image that can rotate in frontal RAO, LAO with a real-time image. Takes some time, takes some experience, but now we do it in a few minutes, not more than that. So once you get the experience, you don't waste a lot of time. And I think for me, it's easier than do a rotational angio with my angio machine or with my C-tube during the procedure itself. That's another option. You do the rotational angio with the fluoroscope, well, not with the C-tube that can rotate, and use that as an overlay in real time. That's, for instance, what Gregor Krins in Utrecht is doing. That's another option.
Thank you. Very, very, very interesting. Very, very good images and well, CT scan and overlay.
Yeah, I didn't take the ugliest, of course, but still, we do it in every patient where we think we should do it, and it works all the time.
Okay, we can discuss a little bit over the procedure. Some questions on the procedure. First of all, on young children under 25 kilos, what type of stents do you implant, and I suppose you consider body growth, and what's the maximum diameter in the stents you implant?
Okay, let's move along. If it's working, there you go. Let's see what I can find on that one. Okay, that seems okay for your question there. For the young ones, I still prefer a simple balloon dilatation. Certainly knowing that from the literature that the incidence of aortic wall injury is pretty low at that young age. But as you can imagine, sometimes the results of a simple balloon dilatation are not good enough. And a few years ago, we would send kids with an unsuccessful balloon dilatation to the surgeons, or just wait a few years to stent them later with adult size stents if you want. Nowadays, we changed our policy a little bit, and we would consider inserting a formula or a Valeo stent. Those are the two stents I use that can be dilated up to at least 14 to 16 millimeters later on. You see a few articles about the formula stent, the Valeo stent. They are available. Those stents fit in a 7 French sheet. They have a hybrid design and are very flexible. That's positive, but certainly the Valeo stent, in my opinion, is more prone to recoil, despite all the encouraging bench testing you see on the screen. But overall, radial strength and foreshortening of those stents, even when they are later on dilated up to an adult diameter, are still acceptable. And I think I have, yeah. Here you see a balloon dilatation or the result of the balloon dilatation in a young kid. And you will agree that the result is not really that nice. And here in that kit, we inserted the Valeo stent, a little bit too long, I guess. But on the long term, when the kid grows to be an adult, that additional length won't be an issue anymore. So this is a stent now dilated up to, I'm not sure anymore, I think 9 to 10 millimeters. And that stent can be easily dilated up to 14, 16 millimeters, which is enough in most of the adults. So, so we changed our policy a little bit, but as I said before, I'm still reluctant for primary stenting in these young children. And the only exception would be the bailout procedure with the coronary stents in the very low birth weight infants, which is very rare. But even then, later on in these premature children, you will need stent removal and corrective surgery anyhow in a second time. So in my opinion, still prefer primary balloon dilatation, but if the result is not okay, I'm moving further on for stent implantation, even in the small ones.
Even in the small means means over 25 kilos always.
No, below 25 kilos. Below 25 kilos, if the result is really disappointing, I wouldn't hesitate to insert really those types of smaller stents fitting in a 7 French sheet that you can easily updilate up to adult sizes later on. But I don't want to do it as a primary procedure for now.
Thank you. My next question is on covered stents. So the most used covered stents are the CP stents due to their radial force, especially in the aorta. But as you said in your presentation, there are other options available like Andra or B Graft. But they are more flexible. They have less radial force, and because of this flexibility, they might fracture less. And for giant aneurysms, another option would be endovascular prosthesis. So I want to know a little bit what your experience with these different types of covered stents, the Andra, B Graft, and with the endovascular prosthesis is.
Okay, first, on the CP stent because it's becoming less popular than before. But for years, I was rather pleased with the covered CP as my workhorse, if you want. I was okay with just one 34 millimeter covered CP on my shelf, and that was suitable for almost all older children and adults with a not too complex coarctation. It can be crimped on a B balloon, which allows for a stable delivery. Its radial force is very good. And the inconvenience were, in my opinion, the cover that is very fragile, and you have to be very careful not to tear it when crimping the stent on a balloon. And you have to be cautious when you introduce the covered stent in the long sheet. This problem was solved by pre-mounting the stent, as you see here, the noodle stent now, which comes pre-mounted, is a covered CP stent. The other problem is the profile when mounted on the regular B balloon is large, and the CP stent is not flexible, not before insertion and not after insertion. Its radiopacity is good, and you can easily see a fracture, although in my experience, this really doesn't occur very often. And I had only a few when we redilated a stent that showed some recoil. We discovered fractures after the dilatation, but I'm pretty sure they probably were there already before the dilatation. We just didn't see them, or we didn't look for them. But anyhow, I would still be happy if the CP stent was the only stent available during a procedure. This being said, for a few years, we had not many alternatives. I used the Advanta stent for a while, as you mentioned it. I was really not happy. I was not happy with the incidence of recoil. There were some warnings about deformation of the cover, the so-called inblowing and restenosis. And then more recently, we got the first one, the B graft. That's a pre-mounted stent with the EPTFE cover fixed over the edges, as you see in the middle. In the middle, you see the B graft stent. Its profile is smaller than the CP stent's profile. It has a still decent radial force, and what's important, it's flexible before and after delivery. And until recently, the Bentley and the manufacturer had the largest range of stent lengths on the market. But meanwhile, CP and Optimus have longer stents available, commercially available right now also. In my opinion, the biggest inconvenience is a single balloon, as you prefer a B balloon as I do. And I tried it a few times. You try to remove the B graft stent from the original balloon and crimp it on a B balloon instead. You risk to damage a new balloon during manual crimping. I discovered this twice, and it resulted in a pinpoint leak. And what I saw was incomplete deploying of the stent in the body, and of course, due to the leak. And we solved this by inflating the balloon with a contrast injector. But I can tell you it's an additional and unnecessary stress. So you have to be careful remounting that B graft stent on a B balloon. For fractures, I didn't see any fractures, but due to the hybrid design, it's difficult to assess fractures of this type of stent. And now, recently, since a few months, the new Optimus stent from Andratec became commercially available to us. You see it on the left side, also a hybrid type cobalt chromium stent, just like the B graft, but the PTFE does not cover the outside cells, or if you want the edges, just like in the CP stent. It's a comparable design there. The radial strength is less than the CP stents, about half. It can be crimped on what the manufacturer delivers, a Gemini kind of a B balloon, and its profile is a little bit lower than that of the CP stent. And due to its hybrid design, the stent is flexible, of course. Radiopacity is rather poor for this stent, and again, fractures are certainly not easy to assess and to discover. Another thing is the foreshortening of B graft and Optimus stents due to their hybrid design is less than the CP stents foreshortening. Of course, this depends also, you see the tables there, it depends on the estimated diameter range of the stents. It differs for an L, XL or XXL, as it differs for the 8 to 10 zig of the CP stents also. The higher profile, that's something you can deal with. A possible way to deal with it is choose a smaller balloon for the initial inflation. I think that's a nice trick. Be aware that it's only possible to do that in case of a tight stenosis, but once your stent is deployed with the smaller balloon and its position is stable, you can remove that small balloon and advance a larger balloon through the same sheet and further dilate the stent to the desired diameter. You win a few French doing that. So that could be a nice way of dealing with a larger profile and saving your vascular entry. About the self-expanding and the vascular prosthesis, I don't have any personal experience with them, but once in a while, I send a patient to the vascular surgeons for such a stent if I have really a large aneurysm to cover in aorta without a real stenosis in which I could use as my anchoring point for my balloon dilatable stents. Or if I think that the anatomy of the aorta with some narrower parts, some larger parts, that in those cases, a self-expandable stent, and you have some that take into account differences in diameter of your aorta, and those will have a more reliable wall apposition and will increase your chances of complete exclusion of the aneurysm. So sometimes I'll send my patients to the surgeons who just insert those stents, but I don't have any personal experience. But there again, there is some literature now becoming available in the last few years about the use of self-expandable stents with some pretty good results, but some complications also. So it's not the holy grail neither.
Oh, thank you very much. I was asking this because we have a couple of cases of giant aneurysm that we tried to exclude with a customized CP stent that was built with the exact length that we needed. But our experience was not optimal, so that's what I was asking about the self-expandable prosthesis.
Yeah, I think if you're looking at your CT that you took before the intervention, and you wonder whether your CP stent or whatever balloon dilatable stent you use will have a nice covering, a nice opposition of the wall, I would switch to a self-expandable stent.
Yes, our option was TP because of the radial force, but next time we'll do a different strategy. And
the radial force is important if you really have some narrowing left, residual coarctation, but in some cases there is no coarctation left anymore. And those are, I think, the cases where you would wonder whether a self-expandable stent would not do the trick, trick better than a balloon expandable stent.
Yeah, exactly. That was our problem. And we also have on the shelf always the B graft. And as you mentioned, that the problem for us is also the absence of a bib balloon. It's a single balloon. And in those cases, we use ventricular pacing that makes it a little more.
Yeah, sure. For sure. That's what we do also. But so once in a while you think, oh, maybe I would love a little bit more control with the bib balloon, but be aware that you can damage your balloon when changing. And in those cases, maybe the Optimus stent from Andratec is a valuable alternative.
Yes, thank you very much for those tips. The next part that I wanted to ask about is, what do you do in the follow-up? You mentioned just a minute ago that you do not have many fractures. Do you search for them in the future, or you just, when you implant the stent, if you do not see any fractures, you assume there are no fractures? We usually perform in the follow-up, not frequently, but once in a while, we do a CT scan where you can see the fractures or the aneurysms related with the fracture. Or in patients that we have doubts, we just put them on fluoroscopy for just a couple of seconds to see if the struts are moving. So I wanted to know, what follow-up do you recommend of your patients, and if you actively search for fractures and aneurysms in the follow-up?
Yep, good question. I think what I do is what everyone does. I check my patients before discharge and a few weeks after the procedure, and I usually do an echocardiography as my standard imaging tool. To be honest, I think the information of echocardiography after a stent in an adult or an older patient is not very reliable. Doppler gradients are not reliable, except if they are low. If they are low, it's okay. And you certainly have no reliable view of the stent or any aneurysm. So what we do is on yearly follow-up, that's the rule for our patients with the coarctation that has been stented if they're doing well. We ask for a frontal and a lateral X-ray of the stent in the first few years. I think if the stent lasts for a few years, the risk of any fractures is becoming less. And that's working nicely for the CP stent, I think, if you're really looking for fractures on that X-ray. And it doesn't work with the hybrid stent, in my opinion. If we're not confident with the X-ray, we ask for a CT or a rotational acquisition in the own cath lab to have a better information. Of course, you will see any fracture of a CP stent with a CT or a rotational angio, that's for sure. But even that will not help you with the hybrid stents. But in my opinion, as long as the configuration, of the hybrid stent is intact and it looks as the stent you implanted, and it's not deformed or there is no restenosis, you can be confident that even if there is a fracture, it's not important. So I really have a good look at the configuration of my hybrid stent afterwards. And if it looks okay, I don't think there is reason to think that there will be important fractures. Of course, for aneurysms, you need your CT, and we do it in the first few years on a regular basis, so that means every 1 or 2 years. And then again, if you don't see an aneurysm after 4 or 5 years, I think that the risks that the aneurysm will become evident later on are low. And if you want any anatomical information or restenosis or information about restenosis, the CT remains a modality of choice here. And here you see some examples. That was a stent that we implanted, and it was already there, I think, the duct ampulla, and you see the stent, the position is not nice. It's protruding anteriorly, and we were not confident that the struts, that the edges would not protrude into the wall and cause damage. And on the CT images, we decided to put another stent here, and I think this configuration is a lot better. Here you see a CT from an article of Turner patients where you see bleeding despite the stenting, and here you see also Turner patients where you see some, and that happens even with a covered stent. You can get an aneurysm at the edges of the covered stent. So that's exactly what's shown in the literature. Whether you use a bare or a covered stent, you can still have aneurysms, but aneurysms at the proximal or distal edges of your stent. So a covered stent will not prevent aneurysms for 100%. So even then, you need your CT for control. That's our follow-up, I guess.
So you consider that if after 5 years you do not see any aneurysms, you consider it's enough follow-up? Because when
I think having put a stent in a patient has not the same natural history as aneurysms after surgical patches. But it's my personal opinion. If you don't have an aneurysm, a small aneurysm, which you will discover with your CT in the first few years after your stent implantation, I don't think that you have a big chance of having an aneurysm later on. But it's just my personal experience.
Yes, because it's a lot of radiation, like every 2 years.
Well, it's not enormous, but if you're doing a CT scan every 2-3 years in a patient that has a life expectancy of 60 to 70 years more, then it adds up to the total irradiation, lifespan irradiation for that patient. I think we all should be aware about the life expectancy of our young, especially the young patients, and they have not 5 years of life expectancy as in the older adult, but 60, hopefully 60 years, and you're adding just irradiation to irradiation to irradiation. So always have to be aware about irradiation. And take it into account in your plan.
Implant a stent at the year of the implantation, we perform a CT scan, and then we wait a little longer the next time because, well, the theory says that the aneurysm starts, and the wall injury it starts at the moment when you implant the stent. So if the wall injury perpetuates in the future, then the aneurysm will grow, and if not, we will not have that aneurysm. But that's the theory. We really don't know how that.
I think it's reasonable, Maria. I'm not sure that every aneurysm is already there immediately. You can have some vascular damage and have an aneurysm, I think, a few months, a year later, but I would be surprised to see a new aneurysm in a patient after a stent that is stent-related that wouldn't be there in the first few years. So I kind of agree upon that.
Well, thank you. That's very, very educational. Thank you very much, Dr. Lawal, for your this learning chance.
My pleasure.
At the end of this premiere, I want to thank everyone who made this possible. Thank you, Daniel, for your lecture with so many practical points. Thank you, Maria, with all your interesting questions. And thank you, Domenico, for organizing this and all the technical work. And last but not least, thank you, Linda Borchers from the AEPC office to help us to bring this channel into air. Thank you all.
Thank you very much.
Bye all.